happy to be able to um, give any information to patients, providers, or whomever out there. I have no disclosures, no industry ties or anything like that. A little disclaimer at the bottom, obviously this is meant to be informational and not intended as medical advice. Some of the information on here may actually be just my own opinion about certain things. Obviously I'll stay medical, but they're also not the opinion of my employer here at Rush University Medical Center either. We do have a great facial paralysis and rehabilitation team here. Myself and Mark Wyatt, who's a neurotologist, head the team. And then we have great partners in neurosurgery, neurology, oculoplastics, other facial plastic surgeons, and of course, the nursing support staff, physical therapy, and all those that really make it possible. Dr. Kochar just already mentioned my kind of background training at Cleveland Clinic and Johns Hopkins before coming here. The things we'll talk about today, I think, and that's our hospital there just on the west side of Chicago. But things we'll talk about are the concepts of facial perception, which I think are important to understand anytime we're talking about facial paralysis. And then treatment options for facial paralysis, treatment options for synkinesis, and then some future directions or things that we might be thinking about. Things I always like to mention at the beginning of any talk when it comes to facial paralysis and or synkinesis is really the 5 facts of facial paralysis and synkinesis. So number 1, the cause and presentation of this, or how people are affected by it, is highly variable, and anybody that is affected or works with patients that are would easily notice that. It is an extremely personal and life-altering experience to have weakness of the face, paralysis of the face, or even just synkinesis, which I shouldn't say just. Synkinesis can be incredibly life-altering and bothersome. There are no minimal or maximal times for treatment. So even if you had facial paralysis 35 years ago, there may be things that we can do that can help your experience with it. I put some stars there because as we do go through time out from treatment, options do change. And so that's important to note, and important to see somebody well-versed in facial paralysis early on, so you can kind of talk about what options you might have from the beginning. It is uniquely individualized. Since the cause and presentation is variable, so is the treatment for it. And so a course of action may be very different one patient to the next. And then research and treatment options are rapidly growing. So as I mentioned, things years ago that we did may still be options now, or we may have more options than we did then. So as far as the concept of facial perception, I always put this statement in my talks too. The face is one of the most important stimuli that carries social meaning and the primary means of social communication. And I'm sure everyone realizes this, and some people have told me in the past years, well, virtual communication or texting and things like that has taken over, and maybe the face isn't so important. I would say it's just as important. Because you can see here, emojis are faces that we send to each other with emotions or with expressions on them. And then, of course, there's a blurry picture of a Zoom meeting, which we're all very familiar with. Obviously, we're on one now, where we're looking at other faces and communicating with facial emotion and movements. In social cognitive science, in 100 milliseconds, we will see someone else's face, assign meaning to it, and basically judge it. To put that in context, and 300 to 400 milliseconds is an eye blink. So in a fraction of an eye blink, we can see somebody and decide, are they a threat? Are they mad? Are they happy? Are they sad? And facial paralysis or synkinesis can disrupt that a little bit, and cause us to be confused by what we see, or to perhaps even judge somebody negatively. Our brains are highly tuned to this, to the appearance of people's faces and the expression of people's faces. I always like to talk about how this might be an innate thing. That's a picture of my son just after he was born. But as early as 30 minutes after birth, babies will pay more attention to faces. If you show them a face versus a picture of a car, they'll pay more attention to that face. As early as 3 days after birth, they'll pay more attention to their mother. So they obviously know that that face is more important than other faces. So there's probably something innate with our ability to recognize and judge faces. In fact, infants tend to look more often or longer at symmetric faces. And so obviously symmetry or asymmetry in faces can be a problem. And there's this idea that beautiful people or the most acceptable faces are average. So they're symmetric, they're an average of other faces. And if there's asymmetries, we assign almost a social penalty to that. We judge them differently. So the face is a very complex intersection of form and function. We just mentioned that asymmetry is a big deal when it comes to faces, but certainly the face is also very important for everything we do day to day, for eating, for speaking, things that are important for communication as well. Intake of senses, so vision is obviously important and affected by or can be affected by facial paralysis. Hearing, smell, all that is an intersection of form and function. And then obviously when someone has facial paralysis, like this picture here, not only is form altered, and we notice that right away, and everybody quickly notices that something is wrong here, but then her function is dramatically altered in many ways. I think an important thing about this talk, because I was asked to talk about paralysis and synkinesis. So an important thing is to highlight, well, what is the difference? And it can be very difficult for trained physicians to tell which one is going on. And certainly for patients or patients' families or friends, it can be very difficult to separate the two. So I'll give my kind of simple ideas of definition. So paralysis or paresis, which paresis is just paralysis that may get better. Paralysis I think of as it's permanent, it's not going to get better. But either one of them is an irreversible or reversible loss of movement. So those muscles cannot move or are very weak in moving. That's paralysis and paresis. Synkinesis, on the other hand, is abnormal movement of those muscles or abnormal tension of the muscles. So they're abnormally taut. And many times I'll see synkinesis patients and they say, well, I'm paralyzed, I can't move. And that may be quite true, but they may have abnormal tone of those muscles. So sometimes it's very difficult to separate the two, but it's very important because it makes a difference in treatment options. And just another example of facial tone, because sometimes that's a concept that can be difficult. Tone is just the resting kind of tightness of muscles. And I tell patients all the time that we all have facial tone all the time, even if we're just sitting here. If we didn't, all of our faces will be just drooping down. But we all have tone in the face. And then when you have synkinesis, that tone, it can be altered. And so the face can be tighter in certain areas than in other areas. And that's where a lot of symptoms can come from. Just to review again, start with basics. The facial nerve is basically a nerve that comes out of the brainstem through the skull behind the ear and then spreads out into the face like this cartoon here. And when it spreads out into the face, these signals that come down through the nerve that we see with this arrow here can go to all these little muscles that we see in the face and provide movement to those facial muscles. And those muscles all do different things to portray the complex amount of emotions that we can on our faces. Even at the muscular level, those little yellow nerve branches go down and send signals right to those little different muscle fibers. And so anywhere along that pathway, if that nerve or that wire, as I think of it, is disrupted, it can cause problems with facial movement. So we'll touch on Bell's palsy because Bell's palsy is the most common cause of facial paralysis and synkinesis. So vast majority of my patients that I see in the office for either synkinesis or facial paralysis, it's because of Bell's palsy. And that's basically an unexplained loss of movement of the face. It happens at a frequency of 20 or 30 per 100,000 people per year. It's more common in pregnant women during the first and third trimester. And there's even a little bit of a difference, at least that I've seen, with at which trimester and how good their recovery will be. Third trimester tends to not recover as well. And it can be on both sides in a very small amount of cases. People that see a lot of facial paralysis have definitely seen cases of bilateral. I have a few in my practice, but it's more rare than one side. And the prevailing thought is that it is related to a viral cause, although that's never been definitively proven. So in medicine, we call it idiopathic facial paresis, meaning we don't know why the face isn't moving. But it's important to know that it has a pretty common presentation. So it's a sudden onset of loss of movement in all our parts of the face, and sudden is the key word. So it's usually over the course of hours. Most patients will say, I went to bed, I woke up, and I tried to brush my teeth or drink a glass of water, and things fell out of my mouth, and that's how I noticed it. But it happens quickly like that, or it happened over the course of a day. It's sometimes associated with other symptoms like pain in or around the ear, loss of alteration of taste, or sensitivity to sounds. Treatment options for Bell's palsy. I would say the most important treatment option is prompt medical evaluation because Bell's palsy, as I mentioned, is idiopathic. We don't know why. So you have to figure out, is it any of those other things it could be, and make sure that it's not. It's important that you see someone well-versed in facial paralysis as early as possible. So if you go to the emergency department, you wake up and your face isn't moving, and you go to the emergency department, that's great. They'll rule out all those really bad things. But then I think it's very important that patients get in to see somebody that knows about facial paralysis because not everyone treats initial Bell's palsy the same, and there are some differences in initial treatment that could make a difference in the final outcome. And then certainly you want someone that is going to more thoroughly look through things and follow you throughout your course and make sure things get better and that there isn't something else going on. Other testing or intervention may be indicated based upon that initial evaluation or subsequent evaluation. People that have Bell's, oral steroids and antivirals are really the mainstay of initial treatment, usually high dose oral steroids if the patient can tolerate that. And then antivirals have been kind of controversial. I would say most people nowadays would use that at the initial Bell's presentation. As we mentioned, is a diagnosis of exclusion, though. So these are some of the other things, or some of the other more common things that can cause facial paralysis. Certainly, you want to rule any of these out because their treatment and kind of timeline of improvement are very different than Bell's. So you want to make sure there isn't something else going on. And then I usually tell patients or other medical doctors that I'm talking to about facial paralysis that these types of warning signs, you really want to see somebody sooner rather than later. So if it happens slowly, if you were diagnosed with Bell's palsy and it happened over the course of a few days or a couple of weeks, well, that is probably not Bell's palsy. If it only involves one area of the face, that is of concern. So if only the eye isn't working or only the corner of the mouth isn't working, but the eye is, those are also concerning issues. If there is facial twitching that accompanied it, especially happening days before, that is a problem and probably not Bell's palsy. Other symptoms, we mentioned it can be accompanied by facial pain. Numbness is rare. Weakness of other areas of the body is rare. Even if you have any other symptoms, probably seeing someone, again, that sees a lot of facial paralysis is important to make sure that that's really all you're dealing with. This is a patient, we'll play her video, that presented to me was diagnosed with Bell's palsy, but she had a very atypical presentation. It happened over the course of days and weeks, and it happened to be, unfortunately, a skin cancer that was affecting the nerve deep down. She was treated for it, is doing quite well now, but it's important to know that you really want to rule out all the other things before you get onto that. A lot of my patients now will say, what about the COVID-19 vaccines or vaccines in general related to Bell's palsy? And so I just put a couple things up here because I'm constantly talking to patients about this day to day. In the clinical trials for the two most common vaccines used now in the currently United States, the Pfizer and the Moderna, there were reports in that of people with Bell's palsy. They reported 6 cases in nearly 34,000 patients in that initial study. If we remember back, Bell's palsy will occur normally in 2 to 3 out of 100,000. So if we break that down, we would expect, 2 to 3 in 20 to 30 in 100,000, 2 to 3 in 10,000. So in 30,000, we'd expect 6 to 9 cases of Bell's palsy, and that's exactly what they saw. So most people think this is probably just what we would expect to see, people just randomly getting Bell's palsy and not related to the vaccine. And certainly the American Academy of Otolaryngology has come out and said that people that have previously had Bell's should still get a vaccine. There doesn't seem to be any relation to them getting recurrent Bell's palsy. And then it doesn't seem to cause Bell's palsy higher than we would expect in the population. When the flu vaccines first came out, this was also a hotly contested thing. People thought it was causing Bell's palsy. It turns out same thing. It seems to be related to the population average of people getting it. So probably unrelated to the vaccine. And certainly with COVID-19, the potential issues with getting it probably outweigh any potential risk of the vaccine. So I advise my patients that they should strongly consider getting the vaccine. So let's talk about facial paralysis, and then we'll go on to talk about synkinesis with the time we have left. So we mentioned there are variables in outcome, timeline, and treatment options based on the cause of the paresis or paralysis. So for example, if a nerve is cut in surgery, we want to fix that right away within the first couple of days if we can. If the nerve is weak from a surgery, so you had a surgery on your spit gland or on a tumor near the brain, and the surgery is weak after, but the surgeon was very confident that he or she did not cut the nerve, then it's reasonable to observe the patient closely with a plan for further workup or surgery as time goes on. If the nerve is weak from Bell's that we just finished talking about, or other medical causes, Lyme disease or things like that, then you want to promptly treat that cause and then follow the patient closely. And so we'll talk about some of those things in a little bit. This is just a list of things that I've done in the last year for treatment of, or last couple of years for treatment of facial paralysis or paresis. So you can see the list is very long. There's lots of options, meaning that there's no one magic bullet either. And also meaning that the presentation or the way people experience it are very different. And so it's important that you work with your physician to figure out what is the best course of treatment. So we'll go through some of those things I mentioned. So the immediate issue, the nerve is cut during trauma. So here's a little cartoon. Let's say the nerve got cut here. The patient was in a car accident, gunshot wound, various other injuries can cause problems with the nerve. Well, then you want to do what's called a primary anastomosis, or sew it back together as quickly as you can. That's going to get the best outcome for the patient. Usually you want to do it in the first 72 hours because that's the timeline that we can still stimulate the nerve and look at the nerve, be able to find it easily. So here's an example of a patient that I saw on the left-hand side of the screen there. You see he's trying to move the face around, but he's weak on the right side of his middle part of his face. And when you get back to the beginning here, you'll see that again. He can't kind of get that cheek up as high. So he had a piece of glass fall on his face at work, and he came in and the nerve could not move. So we explored it. We hooked the nerve back together, and you can see in the other video now he has much more movement of that right side of the face. If you look very closely, you may notice some subtle differences in the amount of movement that he has. And that's because, again, maybe not again, but sewing the nerve back together can get us very good results, but it doesn't get us perfect results. There's really nothing that can, at least yet, that can completely make a nerve that was damaged to that degree completely heal back to normal. Let's say the nerve had to be cut during surgery. So the surgeon, to remove a tumor, had to cut the nerve. If you can sew it back together, you can. Many times, though, the nerve has been cut in two separate areas, and those nerve branches or ends can't get back together. So in that case, you can put a nerve graft, or I think it was a little piece of wire that you're stringing between those two ends from another nerve somewhere else in the body. You can also use a nerve transfer, or another nearby nerve that can be another source of power to kind of hook into that nerve to make it work. So here's an example of both of those things. So this patient had a tumor on the left side of her face, and you can see that it looks different, but now she's kind of biting her teeth together, and you see she's getting movement of the face. Now, most of her facial nerve was removed, and part of it was reconstructed with a nerve graft, and part of it was reconstructed with a nerve transfer from her chewing nerve. So she can get reasonably normal facial symmetry, and you can see her movement is a little asymmetric and not coordinated well with the other side, but that's one of the best things we can get with a nerve transfer. So looking at longer term issues, let's say the nerve had to be cut during surgery, or there was a trauma involved, as I mentioned, gunshot wound, a car accident, but now it's been over a year. We usually think of as 1 year as kind of the point where some of these nerve things that I just showed, nerve transfers, nerve grafts, and things no longer will be working. And that's because the nerve ending right near the level of the muscle kind of shrinks down over that year. And just like if you didn't walk on your leg for a year, that muscle shrinks down. But the facial muscles don't come back if you start stimulating them again or start exercising them again. So if you haven't had signals going to them for over a year, oftentimes you won't be able to use another nerve to kind of replug it back in. So we rely on these techniques here: static sling, we kind of just pull up the face; temporalis tendon, where we use a nearby muscle to pull up the corner of the mouth. That doesn't move very much. Some of the studies show that, yeah, you can get it to move if you're very, very good. But even with that, most patients will get about 3 millimeters of movement, which is not a lot. Then there's the gracilis muscle that we can take from the leg, and we can use that. That gets a lot of movement. It's a rather big surgery, and I'll show you some examples. The movement is always a little off. I mean, even in the best of hands, you can pick out which side has a gracilis and which side is the normal side. Here's a couple examples: static sling. So this is a patient that had a tumor removed. She has paralysis on the right side of the face. There was no nerve available, and she was not a great candidate for a gracilis. So we take little strips of muscle covering. It looks kind of like fabric, and we string them underneath. And you can see we can get a reasonable symmetry of the face. You notice there's not a video here of her face because there really isn't much movement to see, or actually no movement to see. It's really just kind of pulling up and getting symmetry in the face there. The temporalis tendon transfer, that nearby muscle that I mentioned, you can see in this picture here, that chewing muscle that goes over the side of the head and down to the jaw, where it attaches to the jaw. We can remove it and bring it out to the front of the face, as depicted in this cartoon here, and connect it to the corner of the lip. And so that can get pretty good symmetry of the face. Again, it doesn't move a whole lot, so I never promise patients that it's going to move a lot and really get them symmetric movement. If it does, then I count that as a win, but we really do it to establish symmetry of the face. And so here's a couple gentlemen where I did this, where we did a temporalis tendon transfer and pulled up the paralyzed side of the face. It's the right side, obviously, in both of these patients. They both had prior surgery years before. And it gets pretty good symmetry. So they look normal when they're just sitting there in a waiting room on a bus. But we'll notice in this picture, there's another gentleman that had the same thing done. You can see on the right-hand video, he's going to start moving the face around here in a minute. And we'll see that he's paralyzed on the right side. But we'll see in the video after the temporalis tendon transfer, things look more symmetric. You can see a little scar on his cheek there where the tendon was attached. But we just don't see a lot of movement in that middle part of the face. Even when he's trying to bite down and show us movement, we can see a little hint of it more than when he was completely paralyzed, but we just don't see a lot of movement. And that's kind of very typical of the temporalis tendon transfer. The gracilis microneurovascular transfer, or gracilis flap, as some people will call it. This is a cartoon I pulled from a paper I'd written years ago with Dr. Byrne about how we actually do this procedure. This is a little better cartoon that I took off a website on different surgical techniques. And you can see the idea that it's depicting here is that this muscle is stretched between the lip and the side of the cheek, that kind of red area there. And you can see the blood vessels that are feeding that muscle. And that's what we do. That's the microneurovascular portion. We use a microscope to hook those blood vessels together, as well as the nerve. And you can get really lots and lots of movement with this, but you have to expertly attach it to the corner of the mouth to get it to move in the same position as the other side of the face. And oftentimes it does not move exactly the same. Here at Rush and many other centers, we harvest a nerve graft if we need to use a nerve to the other side of the face through an endoscopic technique. So this is myself and my partner just harvesting one here. It can lead to a single incision behind the ankle. And then you can bring that through the face from the normal side of the face to the affected side underneath the lip. And that could be used to help power or only power the muscle, or you can use a chewing nerve to add into it. Here's a picture of that muscle sitting on the back table, and that's how it, markings on a patient, how we would implant it into the face. Now you can see that muscle picture there. It looks like a little bit like a steak. And you can see the two things kind of coming off it. And those are the blood vessels and the nerve that we would use to get it both blood supply and power. So here's a gentleman that had a trauma. You can see there's other scars on his face, but he had a gracilis on the left side of his face. You can see he can get some movement that he can match with the other side of his face. You notice that coordination of that movement is difficult. Here's another patient that had a a surgery years ago, and then we did a gracilis about 20 years later. You can see he can get some movement of that right cheek, but again, coordination and symmetry is not exactly there, but he definitely has a lot more movement than the patients we were seeing before with those other techniques. Here's another gentleman recently. He's less than a year out from his gracilis, and you can see him paralyzed before there, and then here's him moving after, showing us a smile that he can get, coordinating that gracilis free flap there. So you can see you can get pretty good smiling with it and facial symmetry. So I think what we see more commonly than these long-term issues is kind of the medium-term issue. The nerve is weak from surgery, but the surgery wasn't, the nerve wasn't cut. And an example that many people may be familiar with is an acoustic neuroma or vestibular schwannoma. So this is a benign tumor that affects or is near the hearing or facial nerves, and surgery can sometimes affect it, or the tumor itself can affect the facial nerve. These patients we watch very closely. If we don't see meaningful movement before a year, then we'll do one of those nerve transfers or using another nearby nerve to plug into it that we talked about before. Some people will consider some off-label medications for nerve healing in these patients, and I know some centers are starting to use calcium channel blockers. There's been some indication in animal models and very limited human studies that these basically blood pressure medications may help with nerve healing. So if it's not contraindicated, sometimes we'll offer this to patients. The issue with this is that recovery in these patients will come in different groups, and you see this little square here. Some patients have immediate recovery. Obviously, we don't worry about those patients. They'll be weak after surgery, but within a few weeks they start to recover. Or they'll have delayed recovery. It may take weeks to months, but then they get a reasonable recovery. It's these patients on the bottom that have a delayed recovery and maybe just have a little bit of tone in the face but can't move it, or patients that are frankly still droopy or flaccid and cannot move the face at all. Those patients are the ones that we really want to try and intervene on. And unfortunately, I guess fortunately now it's a little bit better that there's facial nerve centers around the country, but years ago most patients did not even get to a facial nerve expert within that year. So some of the options I'm about to present weren't options for them, but now they are. And so again, it's important that if even if a patient's had a surgery and we expect the nerve to recover, that they're followed closely, because if it doesn't recover by 1 year, we want to really intervene pretty quickly to get them some movement. So here's a patient, that very patient. So he had an acoustic neuroma surgery. The nerve was intact, but he's not showing any improvement in the right side of his face beyond maybe a little bit of tone if you look very closely. And so this is kind of our algorithm that we use here. There's a bunch of red question marks in there, and that means that these are decision points or controversies. So areas that we could kind of go either way, or areas where we have to make a decision. This was a study published out of the group at Hopkins that showed that with these patients that have acoustic neuromas or similar type tumors, if you don't do anything by if they don't show movement by about 6 or 8 months, they won't get movement. And so their argument was, well, we should intervene in these patients sooner than a year because they may get better results. And if we're not seeing anything by that time, then we should do something. And so I kind of agree. I tend to wait a little bit longer in some patients because I have seen some improvement. But I will agree that if we're not getting close to that year and not seeing any meaningful recovery, we won't. And so again, 6 to 8 months is kind of what that article quotes. I tend to wait, a little bit longer, but we definitely start having those conversations if we're at 6 to 8 months and we haven't seen any improvement. So we can kind of skip over this in the sake of time, just basically saying that we don't have any ideal reanimation techniques that can do all of these things. We cannot replace normal facial movement in a patient that the nerve has been dramatically damaged. We can get close, but we can't ever make it completely normal. Someday we will be able to do that, but unfortunately, we have to rely on techniques that are not quite as good, but can get us reasonable results. So what nerves do we use for these transfers? Well, there's a whole bunch of different ones that we use. Hypoglossal nerve, or the tongue nerve, was very popular years ago. The masseter nerve, and that's a different chewing muscle of the face, was popularized about 15 years ago. Spinal accessory has been used. combination is what's kind of more and more used nowadays, and that's what we tend to do here at Rush. So there's all these different interventions we can do, and we really want to figure out, well, what's going to be the best for the patient and work with them. That decision is really made on the age of the patient, how much surgery they want to have, or how much of a candidate they are for more surgery, other medical problems. But since none of the nerve transfers is ideal, we really try to harness the advantages of more than one. And we just have a paper that was published last month, looking at the two different main types of nerve transfers, the masseter nerve transfer and the hypoglossal, as to which one is better. And it's a toss up. The masseter nerve shows improvement much quicker. But in my mind, and what some of the studies have shown, that it does not seem to produce as much tone or kind of resting tone of the face if you look very closely at it as like a hypoglossal jump graft. Now, again, this is a very debated topic, and we may see other papers that come out that can look at it closer, but the available evidence we have shows that neither one is completely ideal. So we say, well, then until we have greater evidence and there's not much problem or difficulty for the patient, maybe we should use both. And so that's what we do. So here's a patient. He had a masseter nerve graft. So you see, obviously he's weak on the left side, but when he bites his teeth together, he can get pretty darn symmetric. And that's great. I mean, he has great movement, much more than we would ever get from any of the other techniques. And it looks very natural, matching the other side of the face. He does have to clench his teeth, but unfortunately, when he's not clenching his teeth, when he just is weak, the other side does not look matching the other side. Here's a patient that had a combination of nerve transfers, so a hypoglossal and a masseter nerve. And you see, even at rest, she looks very normal. When she bites her teeth together, she can get that side of the face to move quite a bit. And she can, she's not very good at coordinating it yet, but she can get a reasonable smile from what was a completely paralyzed face. And here's that gentleman we saw earlier. So he was paralyzed on the right side after his surgery. We did a combination nerve graft, and you can see he has tone. And then when he bites together, he can match a smile pretty well to the other side of the face. And he's now showing me that he can actually do different things. So when he bites his teeth together, I think it'll loop back here. When he bites his teeth together, he can get a very nice smile. And the tone is there, and he can actually move his tongue. He gets a different amount of movement or tone in the face by moving his tongue. It's just showing that both of those nerve grafts actually did do something different. They both grew in and are affecting the facial nerve. So let's say it wasn't a surgery, but maybe it was Bell's or another medical cause that caused this issue. Well, then the chances of recovery are much better, but that doesn't mean the patient shouldn't be followed. So we shouldn't say, well, it's Bell's palsy, we'll see you later, you're going to get better, because there's other things that can happen. So these are the patients that commonly develop synkinesis. And so these are the patients that I hold really closely. We see them every 3 months, because if synkinesis starts to develop, we want to have a plan together and how we're going to treat that. And we also aren't sure that if intervening earlier in synkinesis may prevent it from getting worse. And hopefully we'll know some of that in the next few years. In the first year, you can try other things, though. So facial massage, acupuncture, facial retraining. Now, none of this has been shown to necessarily help, more so than just leaving it alone. But there hasn't been great studies. But also, none of it has been shown to hurt. And I definitely have patients that have undergone acupuncture and think that it helped quite a bit in their overall pain or tightness or even synkinesis. I have the fortunate experience to work with several great facial retraining therapists. There's some great ones in Chicago. Jackie Deals, who's a leader in the field, is a few hours away in Madison, Wisconsin, and her and I share a number of patients. And so I think there's a definite benefit to facial retraining, both early on and then after intervention, especially. And I mentioned some off-label medication uses. I mentioned before, calcium channel blockers. Some centers are using longer-term antivirals, especially in patients that may have had like a herpes zoster type of paralysis. There may be some use to this. Now, there's pros and cons. So, and it's an off-label use. So you definitely want to discuss with your doctor and make sure that it is something that would benefit you and not cause any undue risk. So the last few minutes I have left, I'll talk about synkinesis. So this is probably one of the most bothersome symptoms in patients after Bell's or other facial nerve injuries. And you notice in this video here, as this gentleman's moving his face, there's certain things that are happening when the other side is moving when he's closing his eyes. The mouth is moving. He's actually was paralyzed on the right side, but you notice that side seems, the creases seem deeper. And when he moves his eye, his mouth moves. And these are the things that patients commonly talk about. So synkinesis, my simplistic way of thinking about it, because we don't really know exactly what's happening, is that those signals that go down the facial nerve, instead of going in the direction they should be, sometimes those signals, whether it be from nerve regeneration, or signaling transfer, are getting crossed over and are kind of turning around, and signals meant for the eye are going to the mouth, or vice versa, or signals are just more amplified to the face than they should be. So those facial muscles, like we said, instead of being droopy, are actually more tight. And so patients will notice that that side of the face, the creases are actually deeper, but the muscles aren't moving as much. And so that's where the confusion can come in. Well, my face is paralyzed, but actually it's not. It is just pulling so hard that it can't pull anymore, and we can't get movement. So these statements are things that I hear every week from patients, and these are the common things that we'll see with synkinesis. So your eye closes when they smile or eat or pucker their lips. Their mouth or cheek moves when they blink. There's bands or tightness or lines on one side of the neck and not the other. The lines on one side of the face are deeper than the other one, or the eyebrows in a different position. Though it doesn't move, it may even be in a higher position on one side, the affected side, but it's not moving. There's pain, there's crampiness, there's tightness. Or the one that I find that if you talk to enough patients, you'll elicit in most of them, is that there's just an awareness of that affected side of the face. Not even that it hurts, not even that it's crampy, not even that it's tight, but that they just can feel that that side that had bells is different than the other side, and they feel it all day, every day. And that can be a very, very concerning thing for patients. And unfortunately, they'll see doctors and they'll look at them and say, well, your face looks fine. And it may look fine, but that feeling can be very disruptive to patients. This is a little cartoon I pulled off a United Kingdom advertisement for Botox for synkinesis, but it kind of in cartoon form kind of shows some of those ideas that, my muscles are fighting each other, or my talking makes my face hurt, or by the end of the day everything's really tight and crampy. There's twitching feelings, or my eye closes. But I think the thing that they're not mentioning here, which is very important, is that just that awareness of one side being different. Again, it's not often easily noticed by most people. Patients with synkinesis often will say, well, my friends or family say they don't notice it, but it drives me crazy. So that doesn't mean, even if it can't be seen, doesn't mean it does not create a significant issue. Luckily, insurance is increasingly recognizing this and paying for treatments for synkinesis. So we have several research projects that are kind of looking at the effect of synkinesis on people. But the first line therapy for this is really Botox, or botulinum toxin. Botox is just one brand. There's other ones like Xeomin or Dysport. Basically it works at that muscular level. So we mentioned those nerves go down and attach right to the muscle and send little signals across there. What botulinum toxin or Botox does is basically just blocks those signals. So it stops muscles from working. So it doesn't help on the side in people that are paralyzed, because it paralyzes muscles. So if you're already paralyzed, it doesn't help. But people that have synkinesis, where the muscles are moving abnormally, or maybe are moving too much or too tight, it can be very helpful and relaxing. Both kinds of patients, paralysis or synkinesis, can benefit from Botox on the other side of the face, because it can help just provide balance to those muscles on the unaffected side that might just be moving more than the other side. And it can help just provide balance and symmetry to the face. Pros and cons of botulinum toxin therapy. Well, the pros are it's very safe. It's been used for years and years for many indications. There's no evidence of buildup over time in the body. It only acts where you inject it. So if you inject it somewhere you didn't mean to, it's not going to go into the bloodstream and affect anywhere else in the body. And it only acts at that nerve muscular junction. So if you took a bunch of Botox and injected it right into the facial nerve, it would do nothing, because it has to be right at that nerve muscular junction. It is reversible with time, so you can't reverse it with any medication, but if you just wait, usually it's 3 or 4 months, it will wear off. Universally, it wears off. So that's a pro and a con, because if it's helpful, it will wear off and you'll have to do it again. It's very good at treating the eye symptoms. So the eye closure symptoms are the blinking that people get. It's also very good at creating treating that tightness of the neck or of the face. Um, it's not so good, as far as the cons, as getting improved lip movement, and that can be sometimes the most concerning thing for patients that have synkinesis is the amount that their upper lip moves. The reason it's really hard to get consistent results and good results with that is because there's about 7 muscles around the corner of the mouth that make that corner of the mouth move, and all have to coordinate themselves together when you're smiling or moving your mouth. And Botox is a little non-selective. It doesn't affect areas that you don't inject it, but the muscles are so close together there that when you inject it, you may catch another one of the muscles and cause something that you didn't intend to. And again, I mentioned it's reversible with time, but that can be a problem because um, people don't like to come in every 3 or 4 months for injections. But I would say most patients are happy to do that if they get relief from it. So here's a patient again with synkinesis. You see on the left side of her face when she's trying to smile, the lip isn't really moving up, but her eye's closing. You're seeing some tightness of that side of the face, and she has tightness in her neck and things that we can't see that bother her. Some of the tightness in the face, it can be relieved by a simple injection inside the mouth. This was described well in the literature in 2017. So really just 5 years ago, we started doing this in a really meaningful way, or 4 years ago. And this can help tremendously with patients' tightness or pain in the face. So that just kind of highlights that this is still very evolving field. And so continually following up for discussion of treatment options can be helpful because new ones do show up that we can incorporate into people's treatment. This is just a diagram that Jackie Deals, who I mentioned is a great facial retraining expert. The patients that we work with together, she'll send me these diagrams, or they'll walk in my office with these diagrams of where she thinks the Botox will be most effective and what dose. And we'll often do exactly that, and patients get good relief. Sometimes I'll add things in, sometimes I'll subtract things, but we'll all work together to get the patient the best possible result. Selective denervation. So the last few minutes, I'll talk about this. So this is the newest thing out there for patients with synkinesis. It was well described in an article by Dr. Azizadeh that was published last year. But basically, because the idea behind synkinesis is that these muscles are getting too much signal, are moving when they shouldn't be, are getting confusing signals, we might be able to go in there and find those little nerve branches and cut the ones that are misbehaving, leaving the normal ones there. When I describe this to patients, a lot of them look at me with disbelief, saying, "You're going to go in and cut these nerve branches when my face didn't move for 3, 6, 9 months." I don't know about that. And I agree with that. You have to be very careful. It can be very helpful for smile improvement. It can be very helpful for tightness in the neck and the cheek. If you are able to identify those nerves and cut them, it can get patients a lot of relief. It's kind of a big surgery in the classic way that it's described. It involves a facelift incision around the ear. You lift up all the skin off that side of the face and you find those nerve branches and cut them. So that does involve an incision around the ear. Now, many doctors that perform this procedure also perform facelifts. So they're very good at hiding scars, and we can make the scar look very good, but it still is a scar that we have to create in the face. The classic technique is not designed or isn't good yet at improving eye symptoms. So I tell most patients that we're talking about it that this isn't going to make the eye symptoms better. So you're probably still going to need some Botox to help, or botulinum to help the eye symptoms. And so that's an important thing to note, that this isn't going to necessarily make the patient free of needing botulinum injections. So that shouldn't be the goal of surgery, but it can dramatically reduce the amount of injections we have to do. Patients need to be well selected. Again, it's good for certain things and not others. So we want to make sure that we're seeing which patient is going to benefit and they know what the benefit's going to be. It can recur. I know a group that does a lot of these surgeries is working on their recurrence rate. So if you don't cut enough of the nerve, or sometimes the nerve can just be very tenacious and can regrow and find the other end, and it can come back. I usually will put clips on either side of the nerve and remove a pretty good section of nerve to make sure that it doesn't come back. Other groups will wrap the nerve so there can't be regrowth, but it can still happen. And sometimes it needs revision. So sometimes we don't get quite as much as we want. And probably that's because we are cutting normal nerves. And so we're very selective and careful about it, but also we don't want to do anything harmful. So oftentimes, we may not get exactly the result we want. If there's room for improvement, some patients will require a revision where you go back and find those branches again. Here's just a video of us doing one. There might be some sound there as we're kind of stimulating these nerves, and you can see little vessel loops around the different branches of nerves that we're going to cut. There's a handful of centers in the country. Obviously, there's several in Southern California there. Dr. Kochar performs these types of surgeries, and so you can make sure that you know that your surgeon has done a few of these because it is kind of a technical surgery, and you want to make sure that you're going to get the results you can. One thing that we're starting to do here over the last year is we're kind of terming a minimally invasive myotomy and selective denervation. So we're finding one of the muscles that's misbehaving, the depressor anguli oris muscle that's misbehaving in corner of mouth movement, and also finding some nerve branches and cutting them as well. The pros of it are it's very helpful. It seems to be very helpful for smile improvement. Again, that's one of the biggest concerns for patients. So I think it's very helpful for that. It can also be helpful for tightness in the cheek area, that buccinator muscle we were talking about. We can disrupt some of the tightness there. It's not very good for the neck tightness. So if a patient has a lot of neck tightness, then I usually tell them that this surgery is probably not going to help them. And we'll talk about the more traditional selective denervation procedure. But another pro of the minimally invasive one, there's pretty minimal downtime. So patients don't have to have an incision in front of the ear or any incision on the outside, really. It doesn't involve as much skin or soft tissue movement, so they can really get back to their normal activities pretty quickly. It's not designed to improve the eye symptoms, just like your classic selective denervation. So patients will still usually need some Botox either around the eye or the neck because it's not designed to fix that either. You have to be very selective in these patients because only certain ones will improve from this and some will not. And so those are important things to mention. Here's just a video of, this is actually just a few days ago, one that we were doing. And so we're showing an artery there that we're moving out of the way. And then deep down are branches to the facial nerve there. And we're going to lift those up and we're going to stimulate them to ensure that they're the ones going to the muscles that we hope they are. And you have to variably dissect these out because there's one muscle, especially in synkinetic patients, around the corner of the lip there that you don't want to disrupt. So if we accidentally cut the nerve to that, we may have a result that we're not happy with. And so you see we're putting some clips on the nerve here. We'll cut it in just a minute. And you'll hear the nerve monitor go off as we put the nerve on, or the clips on it. And then after we cut it here, we will then just cut it in a minute. And then we'll retract. The muscle is actually retracted out laterally. That depressor anguli oris muscle is under the blue loop that you see there. And we're going to retract it back in just a moment here after the nerve is cut. And then we're going to cut that muscle. And we'll then show you a result of a patient in just a minute here of kind of what this procedure can accomplish. And so we'll kind of bring that muscle back over, and then we will cut through it with a little electrocautery to make sure the ends don't regrow. And then we'll close that. So it's all done through an incision inside the mouth. So here's a patient that on the side of the screen here, you'll see this is just immediately post-op. So you see she's smiling there. You see on the left side of her face that the smile just does not get as high. She has these strange dimpling around the corner of her mouth and her chin over there. And so the picture on the right side, we'll play the video in here in just a minute. This is 1 week after her procedure. So 1 week. So she, importantly, I like to point out that she has her ID card on. So she was at work and she popped over from work. But just 1 week later, we can see that there's still asymmetry in the movement of her lips, but when she tries to smile, we see much more of her teeth on that left side than we do on the right side. And it'll kind of loop around. We'll show you that again. And so this is just from a simple less than hour procedure with minimal downtime. And she's back in the office within a week. And so I think that's definitely the benefit of it versus the more traditional surgery. You can see around her corner of her eye, though, she has no Botox on board because she's just immediately post-op here. So her eye, she'll need some Botox around the eye there. She still has a little dimpling of the chin, and we didn't quite get the entire mentalis muscle denervated, but a little bit of Botox in those areas, I think she'll be very happy with for that improved smile that she got. So lastly, outcomes measures. I talk about this any chance I can get. This is a rare diagnosis. It's hard for us to get in the numbers of patients to really show big differences. We don't have consistent outcomes. Any good center that you go to will do these things. They'll do pictures, they'll do videos, they'll ask you to fill out forms about how you're feeling. They'll do their own measurement tools just to really try and get a standardized way to do this. So every place around the country that is really a good facial nerve center will do these things. And so make sure your doctors are doing it. This is an article that we published showing that we've been bad about really objectively looking at how our results are. So our program, Dr. Kochar's program, many other programs around the country are really trying to offer the full gamut of procedures, but also collect these data so we can look at them together and figure out how we're doing and how we can help patients. And so I'm more than happy to answer any questions at this time.
All right, thank you, Dr. Revenant. That was excellent. So we do have opportunity for questions. There's a couple comments that were made here. So just so everyone knows, please put your questions in the chat box for security purposes. We can.
I can stop sharing my screen. There we go.
There we go. Great. For HIPAA and security purposes, we're going to hold off on questions or hold off on showing people's faces. One comment here was regarding, emergency rooms sending patients to neurologists and not specialists in facial paralysis. I think that is something that is slowly changing and evolving as emergency rooms are becoming more understanding of Bell's palsy, and facial nerve experts in areas are growing. I'm not sure what the algorithm is for you, Dr. Revenant, in Chicago, but I've certainly been seeing a lot more patients recently diagnosed with Bell's palsy in my clinic than before. Have you noticed any changes?
Yeah, no, I think we've noticed some changes. Actually, my partner, Dr. Smith, is in the process of kind of getting up and running an acute facial nerve kind of center. So we can really go out to the emergency departments and neurologists and say, hey, any patients that show up that have just had Bell's or acute paralysis, send them over. We'll get them plugged in. Many of them won't need anything, and we get that. But some of them will need things down the line. And so having them plugged in early so we can get those interventions and the information to them, I think is very important.
Excellent. One person mentioned facial massage has helped with synkinesis. I think facial massage, if done by an expert in facial retraining, is a great avenue for part of the physical therapy process. The key in that sentence, I think, should be facial nerve expert. There are a lot of doctors or physical therapists out there who offer treatment for facial paralysis, but I would suggest certain things you want to shy away from, any electrical stimulation, especially early on. Down the road after treatment, I found some of it useful, but some things you do want to be careful for regarding that are just making sure the person has experience taking care of patients with facial paralysis. In terms of Buccinator Botox, the question here, does the Buccinator Botox injection affect the lip going up? Do you have any thoughts on that in terms of what the Buccinator Botox?
Yeah, it can and it can't. So that's a tough question. Buccinator Botox can be really helpful in, I find it most helpful in tightness, but it can be helpful in getting the lip a little bit more elevated, because it is one of those muscles that it pulls kind of it's a muscle that helps you push food into your teeth. And so it kind of pulls in and down to the lip. So in some patients, I've seen improvement. Kind of selling it as it's going to improve the corner of mouth movement. I would say I haven't seen it dramatically improve it. It can affect it negatively. If you do too much into the Botox or get it too close to the corner of the mouth, it can negatively affect it. And so most people will do a very small amount to start. And then if there is a benefit, start to kind of decide how much you can go up with that.
Okay, great. There's one other question. Patient describes getting Botox in their eyelid and having it negatively affect their blink. They couldn't blink for 3 months. Is this common? It made me nervous to do it again. How would you counsel that patient in your office, Dr. Ravenel?
Yeah, I would say it's not super common, and you can share your experience in a second. But I think causing it to not be able to blink, I would say that probably maybe there was a little too much Botox used, because I haven't seen many patients not be able to blink. Now, some patients it'll cause maybe a little more dryness of the eye if we're really aggressive with it. I think one issue that we see more than not being able to blink is that it can make the upper lid a little bit low, especially if you're doing upper lid injections, which that's another thing you should definitely do with somebody that kind of knows what they're doing, because the upper lid is a real risky area to inject into. I can understand why that would make a patient nervous, and just like with the synkinesis surgical treatments, we can't forget that patients have had paralysis before, so they know what that is like, and to have this something not move again like it did before, and think, oh gosh, is this going to stay like this? That can be really traumatic. I would say you could do Botox injections again, and I think you'd probably have a better experience doing them again. And so make sure you see somebody that does a lot of it, knows what they're doing, but I think you'd have a better experience with another round.
Okay. And are you at Rush? Are you seeing remote consultations or telemedicine consultations for first-time patients?
Absolutely. Yep. Just like anywhere in the country, this pandemic has changed the way that we do that, but we definitely do virtual visits and virtual video visits. Obviously, or maybe not obviously, but around the country, it does depend on your insurance whether or not you can see us for a virtual visit. But if you call in to arrange it, they can certainly help sort through all that.
Okay, great. Just a couple of points that I wanted to touch upon that Dr. Ravenel brought up. I think all of us who take care of patients with facial paralysis agree that this is extremely personal. It does have a life-altering effect, whether you have a brain tumor or Bell's palsy, depending, no matter what age or sex you are. So our goal is to get patients to the right place. And so when patients call me from Chicago, I almost automatically refer them to Dr. Ravenel or his colleague, Dr. Smith, and to anyone at Rush. And so likewise, our goal is to not promote ourselves, but to promote the best treatment for patients. And I would highly recommend anyone in the Midwest seek out Dr. Ravenel and his colleagues, because he's done tremendous work in just a short amount of time. One last question is regarding facial tightness for patients who feel that they're not so much concerned about their asymmetry, but they just feel the tightness in their face. Do you feel that botulinum toxin, with or without physical therapy, is beneficial, or is there something else that you'd recommend for those patients?
Oh yeah, absolutely. That's probably the most beneficial thing, and certainly the thing that I would start with. Facial massage or retraining can help with that tremendously. I have a lot of patients that just, remembering to stretch it out, just like other muscles in your body. Stretch that out in the evenings may help, but it's certainly worth a trial of botulinum to see if you can get additional benefit or long-term benefit, and have to do less massage. So either thing can be helpful, and combined together may be the most helpful.
Great. Well, we're out of time, but Dr. Ravenel, thank you so much for joining us. We were going to record this, and we'll share it on our platform, on our Facebook site, as well as on other social media avenues, and we'll also allow people to share it and download it as wanted. I think, and the slides will also be available on that video. So for anybody who has questions, please reach out to myself or Dr. Ravenel. We'll be sure to share our professional emails with you as well. And if you need to look up Dr. Ravenel, you can find him at Rush Medical College, or Rush University Medical College in Chicago. Thank you very much. Have a wonderful day.
All right. Thank you. Have a good one.